Well, anyway, I had the pleasure of meeting Dr. Julian Whitaker 2 or 3 months ago when he came into Sedona, Arizona, and gave a very enjoyable evening's talk along with a dinner to a number of people there about heart disease and about reversing diabetes. And we're very fortunate to have him here, and I don't want to take up a lot of his time, so let's give him a nice warm welcome. Dr. Julian Whitaker.
Does this work? Great. First, I'd like to let you know how I got to be, or how I came to use the kinds of therapies that we do now. I was trained in orthodox medicine. I graduated from Emory University in 1970, did some surgical residency at University of California, and in mid-1970, I began reading some of the works of Nathan Pritikin. I thought that this particular approach with low-fat diet was unique in that I'd never been taught that in medical school, a point I'll cover in just a few minutes. I went to work with Pritikin in 1976, and I worked with him for about half a year. And I'd never seen patients with heart disease and diabetes improve so dramatically. I was also impressed with the fact that Pritikin had compiled in his monograph and in his books old literature which substantiated every claim that he had been making on heart disease and diabetes. I went back and reviewed some of that literature. I'll even show you a few studies on the diabetes. And since then, for the last 15 years, I've been using very low-fat diet, vitamins and minerals, exercise. Just started using some chelation therapy in patients who are quite symptomatic. And we have a full nutritional approach to cardiovascular disease. Now, the first slide. This is me. Now, Thomas Edison said that the doctor of the future will, and I'm sure all of you have seen this quote, will give no medicine but will interest his patients in the care of the human frame, in diet, and the cause and the prevention of the disease. Thomas Edison was right, because as of this decade, we do have ample scientific material to let us know that we could not only prevent most of these diseases, but we could reverse them with a change in lifestyle, with diet, and with certain vitamins and minerals. However, Western medicine is, shall we say, market-driven. What occurs in Western medicine doesn't necessarily have anything to do with whether or not patients are benefited, but has a lot to do with the financial or the economic structure of it. We are currently doing 1 million, or rather 300,000 bypass procedures a year. That procedure has failed 2 controlled trials of benefit. We're now doing 300,000 angioplasties per year, which has not even been studied. We're doing 1 million angiograms, the diagnostic catheterization, which has been shown repeatedly in the scientific literature to be grossly inaccurate and to be subject just to a whimsical, subjective opinion. So the scientific literature of what is good or what is efficient for treating patients does not run medicine. Thomas Edison knew this, and we have that information, but we're not putting it to use primarily for market reasons. Everything seems to be run by market. Even love is run by market. As many of you know, the real estate business in California has hit rock bottom, and all the developers are talking to their wives and say, honey, I tell you, we've been together a long time, we've had a nice life, but they're foreclosing on me, we might lose it all. If that happens, are you going to still love me? And what they're hearing is, dear, I will always love you, and I will miss you terribly. So things are market-driven. The scientific literature does not guide the medical practice. Now, how many of you have had an experience with physicians in which you thought they were just basically negative when it came to nutrition? Can I see a show of hands? It's kind of dark up here. Okay. Basically, physicians have a negative bias when it comes to nutrition. Now, I'm curious about that because I had changed my attitude over the last 15 to 18 years to where I'm quite positive, and we both have the same intent. We want patients to get better, but in reality, when you talk to a physician, a cardiologist, about coenzyme Q10, magnesium, chromium, or L-carnitine, it literally is like talking to an aggressively negative brick wall. And that occurs in medical school. And I'm not the only physician that is concerned about it. This appeared in the American Journal of Clinical Nutrition in July of 1988. A group of professors in the Southeastern Conference, or rather southeastern part of the United States, were wondering why so many physicians harbored such negative attitudes toward nutrition and wanted to know when these occurred. So they did a survey of medical students as they entered medical school at 2 years, which is after the basic science, and then as they graduated from medical school, to assess a physician's attitude towards nutrition. And this was done simply by asking these medical students the question, do you think that in your medical career a knowledge of nutrition is going to be important? A very simple question. Upon entering medical school, all of these are highly intelligent college graduates. There was a 74% said, yes, nutrition is going to be important to me in my medical career. By the end of 2 years, it had dropped to 3% had said that. In these, one school maintained a positive attitude at around 68%, and I believe that was the University of Alabama, which had an MD teaching clinical nutrition in the first 2 years. The majority of them had completely given up on the idea that nutrition has anything to do with medical practice. Now, this is unique because of those in this room that are health professionals, we realize that the first 2 years are what we call the basic science. In the basic science, we study biochemistry, we study physiology, we study anatomy, we study histology, we study pharmacology, we study pathology. But when we get into the mechanisms, the Krebs cycle, and all of these things that we learn, basically we're learning how nutritional elements come together in the system to keep the system running and utilizing energy. And somehow the process of studying the very importance of nutrition creates an enormously negative bias. I don't know how that occurs, but I do know that it does occur. So we physicians who are engaged in nutritional practice actually have an uphill barrier to overcome because we're generally seeing patients who have seen orthodox physicians who have implanted in them a negative bias towards nutrition. And a lot of that is so easy to overcome just with the data. This is the basic problem as I see it and as many see it in America, and it is simply our basic nutrition, the foods we choose for our daily diet. If we look at the foods that we eat, meat, dairy products, milk, cheese, butter, eggs, frying, etc., we see that we're eating an animal-based diet. Now, if we take the caloric percentages, we're consuming about 40% carbohydrate, about 20% protein, and about 40% fat, most of it saturated fat. If we isolate countries who have similar dietary patterns, they're going to have similar diseases, primarily associated with dietary fat. Sugar comes in a little bit, absence of fiber comes in a little bit, refinement of grains comes in a little bit, but nothing is as consistent as dietary fat. For instance, the Japanese are quite high sugar and processed carbohydrate eaters, but they don't have anywhere near this cluster of diseases. If we look at the major diseases that we have in this country, diabetes, cancer, arthritis, high blood pressure, multiple sclerosis, heart disease, to name only a few, you have gallbladder disease, Raynaud's phenomenon, serum lupus erythematosus, various other forms of arthritis. We see that a lot of the problems are associated with dietary fat. Now, I want to talk about two of those problems, diabetes and cardiovascular disease, and there are certain things that we will cover, for those of you who are interested, we'll cover in the seminar later, but I want to give an overview of how nutrition can be used to treat these various disorders. And basically it is a stance of priority. As a physician, I put high priority on this. The reason I put high priority on this is because it's powerful and it works. Diabetes is a condition. It's not necessarily a disease, but it's a condition. It is related to, in many cases, the type of food that people are eating initially. If they're eating a diet which has decreased amounts of carbohydrates, now this would be the unrefined carbohydrates, and increased amount of fats, they will develop diabetes mellitus. If this continues, they will develop in a severe fashion. If at this stage they are put on increased carbohydrates and decreased fat, then the diabetes will tend to reverse itself and go backwards. It is interesting that this was well worked out in the 1920s and the 1930s. There was a doctor by the name of J. Shirley Sweeney who in 1927 published in the Archives of Internal Medicine an experiment in which he gave medical students a high-fat diet, did a glucose tolerance test, a high-carbohydrate diet, did a glucose tolerance test, a fasting regimen for 3 or 4 days, glucose tolerance test, and then a high-protein diet. And all of the dietary regimens which restricted carbohydrate, this would be the high-fat, the protein, and the fasting regimen, would destroy the glucose tolerance and would create chemical diabetes. Now, Hinsworth, this is from my book, and I discussed a lot of these older studies in the book, devised 7 different diets. This is 1935. This is pre-World War II. And notice that the carbohydrate calories from diet 1 to diet number 7 go from 200 to 2,000. Protein calories stay the same. Fat calories go from 2,160 calories to 360 calories, and total calories stay the same. So he is simply adjusting the carbohydrate-fat ratios. He is keeping the protein intake the same, and he's keeping the calories the same. And what he demonstrated is that subjected to the glucose tolerance test, those on the high-fat, low-carbohydrate diet had a dramatic presentation of chemical diabetes, and as he went down up the scale from 1 to 7, by increasing the carbohydrates, the glucose tolerance test improved until the best one was diet number 7, or the 75 to 80% carbohydrate diet. Now, at the time he was writing, Hinsworth was publishing this work. This is Rabanovich from Canada. The therapeutic diet given was called the Woodyard diet. And the Woodyard diet consisted primarily of egg yolks, meat, mayonnaise, with the intent of restricting carbohydrates from the diet. It made sense. If you restrict carbohydrates from the diet, you supposedly are solving this problem of elevated glucose. So by restricting carbohydrates, you are using a therapeutic diet, but exactly the opposite is the case. I could convince all of you, unless you knew, I could take you to Kansas and show you a flat cornfield and could easily convince you that the earth was flat. Well, you know that it is round. You know that it is exactly the opposite of being flat. But unless you knew that, common sense would tell you, based upon your perceptions, that the earth was flat. Likewise, it made sense that if you had a carbohydrate or a glucose problem in the blood, you restrict carbohydrates in the diet. That common sense approach has been disproven over and over again, but the overall mentality of physicians still is that you need to restrict carbohydrates if you're going to treat diabetes. Well, Rabanovich challenged that, and this was August 1935. Diabetics are told that if they start insulin, they'll never be able to get off insulin again. Well, Rabanovich challenged, also disproved that. He had 50 cases put on a high-carbohydrate, low-calorie diet in diabetes mellitus. So he's looking at the effects of that. He was able to take 24% of them off of insulin with that kind of regimen, and he quoted that this data is incontestable evidence that the high-carbohydrate, low-calorie diet is more effective in controlling diabetes than all other methods of treatment reported hitherto. I point this out because when was the last time you saw hitherto in writing? This is a pretty old study. Well, we rediscover that. something that has just come on the scene recently that I've been using in some diabetic patients is vanadyl sulfate. There were some incredibly important studies out of Canada with diabetic animals that when they produced diabetes in these animals with streptozazine, which was an islet cell toxin, and gave these animals vanadyl sulfate in their drinking water, the diabetes simply disappeared. There was normal blood sugar levels. There was no thyroid hormone disruption. There was normal fat metabolism. The heart did not enlarge or become fibrotic as it did in the other diabetic animals. And there was no cataract or blindness recorded. The only thing that the vanadyl sulfate did not do was increase the insulin levels, because the toxin had destroyed insulin, but it acted like an insulin. So I read this, I say, this is brand new. Well, vanadyl is on the periodic chart. It is ubiquitous in the food chain. It is in Centrum vitamins. But no one had ever studied it for diabetes, and now these works with animals are coming back. And lo and behold, back in 1899, a French physician by the name of Lionnet had given 3 diabetics vanadium, and 2 of them had cleared their urine of sugar. So we basically can go back and rediscover things that are already there, and if we can pay attention to them, then we will have some benefit. Well, we're now rediscovering the fact that a high carbohydrate diet can reverse diabetic condition. Again, with the high carbohydrates compared to the normal. And in this study, let's see. They found that the insulin level was actually lower on the high carbohydrate diet. Back in Rabinovich's time and Hinsworth's time, they couldn't measure insulin. Now, I give all diabetics dietary fiber. Dietary fiber in this study out of Chicago, with no other changes, had demonstrated a very significant drop in the fasting blood sugar level. And in this study, they pointed out that those diabetics that were taking the fiber had a higher percentage of hypoglycemic reactions, had lower insulin requirements, had reduced their insulin more, had less fluctuations in swing, only with the addition of dietary fiber. Well, what can this do in the diabetic population? Now, Jim Anderson at the University of Kentucky has been publishing studies along these lines for almost 15 years. Back in 1976, he published in the American Journal of Clinical Nutrition a study of 13 diabetic men. These are type 2 now, non-insulin dependent, 13 of them, who were eating the American Diabetic Association diet of 40% carbohydrates. Basically, the American Diabetic Association diet is the American diet. Back in 1979, I accused the American Diabetic Association diet of being an excellent diet to start diabetes, or to bring on diabetes. And this was done in Prevention magazine with a circulation of 5,800,000. There was no challenge to that. If we look at the ADA, the American Diabetic Association diet recommendations, they're not based upon any nutritional science. The only thing that the American Diabetic Association had done is to take the 4 basic food group concept of what Americans were eating to begin with, and then put it in exchange groups, control the calories, and give it back to the individual. You could reduce calories in that way, but you did not change the composition at all. And if you're going to improve diabetics with diet, you've got to change that composition. And you cannot change that composition without having a substantial increase in your vegetable proteins and your carbohydrate foods. You can't simply go from meat to fish. And you can't go from mayonnaise to light mayonnaise. You've got to replace these foods with vegetable foods that are prepared in a non-fat way. Well, he took these 13 men, now this is type 2, but even though they're type 2, 8 of them were taking insulin. On 2 weeks, or rather 2 weeks on the low-fat, high-carbohydrate diet, 50% of those taking insulin became insulin-free. All 5 taking the oral drug became drug-free. Glucose fell to 136, cholesterol level fell 25%, triglyceride levels fell. If we look at what an appropriate high carbohydrate diet could do to diabetics, it can take 9 out of 13, or rather 70% off of medication if it's used appropriately. If you take 70% off of medication and you've got 10 million diabetics on medication, and you take 7 million off of medication, and you're considering that they're spending probably, you know, $500 a year on medication, that's $350 million of medication that could be dispensed with. Now, I will tell you, there are forces that would not like to see that happen. And whether or not they are actively, and I don't believe this, I believe in a lot of conspiracies, but I don't believe that they are actively suppressing nutritional information. I do know that they're not actively engaged in encouraging this, but there is the belief that diabetics need medication all the time, and they're constantly using it, and this kind of approach with 75% carbohydrates is used in only a few places. Jim Anderson uses it, I use it, Pritikin uses it, the Weimar Institute in Sacramento uses it, and I don't know who else uses it. You got 7 million diabetics. I haven't even seen a measurable number of that, and I don't believe anybody else of those people who has either. Well, the oral program in the book on diabetes, I was very careful and wrote a very long chapter on the oral drugs, Oronase, Diabenese, Glucotrol, Diabeta, because they represent such a large proportion of diabetics in this country that are taking these medications. However, a study that was double-blind, placebo-controlled, funded by the National Institute of Health, and was put in 12 different hospitals, tried to assess the value of these oral drugs at preventing the heart attack. In the diabetic population, only 10% of them actually require insulin. 90% have what we call non-insulin dependent. They basically need diet and exercise, etc. But it is this population that is taking these drugs. So 90% of the diabetics are taking some form of oral drug. So they did a test to see if these drugs would prevent the complication rate, because these diabetics do not die from diabetes. What do they die from? Heart attack. Diabetes increases the risk of heart attack some 17-fold. So it's a marked increaser of degenerative diseases. So they wanted to see if lowering the blood sugar level with these drugs would prevent the heart attack rate. It was supposed to be an 8-year study. At 6 years, one of the groups had a demonstrative increase in death rate. That group happened to be the drug group. So rather than actually decreasing the death from cardiovascular disease, the oral hypoglycemic agents were reported at increasing the death of 250%. And the conclusions were that control of drugs of type 2 diabetes by drugs or insulin didn't prevent or even delay complications, and it's probably better if you have this form of diabetes that you wouldn't even be diagnosed or treated. Now, that was reported in 1971, but it wasn't until 1984 that the FDA was finally forced to put a warning label on these drugs. In 1984, the warning label read that the administration of these drugs, oral hypoglycemics, is reported to be associated with an increased cardiovascular mortality. Now, I've seen a lot of diabetics. A lot of them are taking these drugs, and I simply pull out the PDR, open up to Glucotrol or Diabeta or whatever the drug is, and there in boldface type is an explanation of this warning, which brings us to the irrationality of allopathic medicine in this country. The worst thing that can happen to your diabetic patient is to die from cardiovascular disease. There is no more final or more heinous complication of diabetes than to get a call one night that your patient has just expired in the emergency room from a massive heart attack or from a small heart attack or from whatever. That's the worst complication. We're giving drugs that increase that complication. So I don't know how we can satisfy that in a rational manner, but I do know this: it's often difficult to take patients off of this drug, because the patient will say, well, what if my blood sugar level goes up? And my question would be, all right, you can take this drug and you can have an average blood sugar level of 170 if you want, plus a higher risk of dying from a heart attack. Or you can come off of this drug and have a blood sugar level of 190 to 195, plus a lower risk of dying from a heart attack. Which would you rather have? People actually have to think about that. It's like Jack Benny and a mugger comes out of the alley and puts a gun in his stomach and says, your money or your life. And Jack Benny says, don't rush me, I'm thinking. Because we are so conditioned to this blood sugar level being the only thing measurable to demonstrate any kind of reduction in risk of complications, that we will take a drug willingly, having read that it will increase our risk of dying simply because it will lower the blood sugar level. Now, the reason it increases the risk of dying is that it increases the heart's requirement for oxygen. When you increase the heart's requirement for oxygen and you have a progressive atherosclerotic process ongoing, then you have a situation where if you have a small heart attack, it becomes larger because the oxygen requirement of the heart is larger. The second reason is it is atherogenic, meaning, not atherogenic, arrhythmogenic. It causes the heart to lose its natural rhythm. Most people die from irregular rhythm. So now you have given a drug that increases the likelihood of an extensive heart attack as opposed to a small one by increasing the oxygen supply, and a drug that increases the chances of a fatal arrhythmia should a heart attack occur, and that is probably the reason that it carries this label of the mechanism for the observation. And that was done retrospectively. They went back to look at the drug after this study was published back in the mid-70s to see what was the problem, and that was what they found. Oh, by the way, the drug companies were adamant against this, and it took them 13 years to finally to work on its mandate. I'm no fan of the FDA, but I do know that the FDA is pulled in both directions. What about insulin? This was also studied, and this ran actually for 8 or 9 years. And they were giving two forms of insulin. They were not forms, but two mechanisms. One was a standard dose in which diabetics just got insulin and stayed on that same dose regardless of what their blood sugar was. Nobody has that. Everybody has a variable dose. If your blood sugar level goes up, you take more insulin. And this was compared to those who had diet alone. Well, what was the complication rate? There was no difference. No difference in complication. These findings provide no evidence that insulin or any other drug lowering glucose levels will alter the course of the vascular complications in type 2 diabetes. And there's been no study to refute that. But still we have and I'm not one to say, okay, throw away your insulin. That's not the point. But the point is most physicians, and I know most patients, don't think any farther than, and if we try to use things to alter that blood sugar level, then we generally will hit barriers. I'm also concerned with the amount of medication that patients are taking that have diabetes that is not associated with diabetes. This was a study in which 122 patients were found to be taking, or rather 104 of 122 patients that were diabetic were found to be taking drugs that made their diabetic worse. So they may have diabetes, but they also have high blood pressure, they also have cardiovascular disease, they also have cardiac arrhythmia, they also may have angina pectoris, and they're taking these drugs, particularly hypertension with the thiazide diuretic. And in this study, 68% of the patients were taking thiazide diuretics. Thiazide diuretics are what we call diazide, hydrochlorothiazide, diuryl, maxide, induride, all of these drugs that have this particular diuretic. This diuretic in the PDR will elevate the blood glucose level and cause an exacerbation of diabetes, but 68% of these patients were taking this drug, and only 50% of the physicians knew that this drug would make the diabetes worse. Now, this is an extreme example of what I'm talking about, how the use of additional drugs can exacerbate the problem. This was a 65-year-old man that I saw about 7 years ago. 5 years before I saw him, he had mild high blood pressure, and he was put on hydrochlorothiazide. He was in the emergency room twice with low potassium levels, and arrhythmias and low potassium levels. Rather than stop this diuretic, he was given large doses of potassium and another diuretic to counteract this diuretic. So now they're creating a little war in the kidney. He then was given this diuretic in the overall condition, started diabetes, he was put on insulin, and he got up to 130 units a day. He's going to the hospital 3 times a week to have a blood sugar level taken. 130 units. He developed an arrhythmia, et cetera, et cetera. Well, to make a long story short, we cut his insulin in half the first day that I saw him, nothing happened. We cut it in half the second day, nothing happened. The 4th day, we stopped it, nothing happened. We also got him off of the rest of these medications in 2 weeks, so ending, he was only taking vitamins and minerals, diet, fish oil, and some other supplements. What was the result? Initially, he had a cholesterol level of 190 on those medications. 12 days later, on no medications, 159. Blood pressure initially was 126. No medications, 128. Triglyceride levels came down. Blood glucose level here was still normal. And he dropped from 17 prescription medications, including 130 units of insulin, to no medications and no change in his condition. He now he was president of the Mormon Church for years. He's now actively engaged. He's 70 years old. He was at this time about retired, and this was about 5 or 6 years ago. His diabetes never came back. He does have some persistent high blood pressure and is taking some mild medication, but he simply doesn't have the problem now. Now, what about atherosclerosis? Well, heart disease and atherosclerosis will develop when there is a damage to the inner lining of the endothelial cells in the presence of high cholesterol and fat. Here's the inside of an artery. This is the endothelial lining that lines the artery. This is muscle, which gives the artery its pulsatile nature and it makes the artery capable of resisting pressure. This is cholesterol and triglyceride, and these excess amounts of these fat molecules, macroglobulins, will damage the endothelial lining, as we see here, and then it will go into the muscle area, building a plaque. Platelets will form on that, which go off and causing strokes and heart attacks, etc. Again, you will have a plaque of this nature. Now, that's a very educational slide, or set of slides. Unfortunately, it's not accurate. And the inaccuracy of it is that this lump or bump pathology does not normally occur. The process of atherosclerosis will create lumps or bumps, but in general, the process is diffuse throughout the entire arterial system. Because it is diffuse, it makes the angiogram diagnostic procedure inherently inaccurate. That inaccuracy is because when you have a diffuse nature and you're looking for a lump or a bump like this, if it's 60 to 70% blocked the entire length, it looks normal. Does that understand what I just said? How it looks normal? Because the angiogram is a picture of the contour of the inside of the artery after a dye has been squirted into the artery. Well, if that artery is this big and it goes through there, it's going to look normal. If the artery is this big and it goes through there and there is no lump or bump, it's going to look normal. So in order for the angiogram to show something, you have to have a lump or bump of this nature, which simply doesn't occur. This was some studies done in which they pointed out that the finding of a single normal coronary artery segment was rare, that this was a diffuse process. Now, the problem with the diffuse nature of atherosclerosis is that our treatment modalities are local, and they look at the, you have 3 grafts on the bypass operation, you have 2 balloon procedures, and they are static. They're isolated in time. We have a progressive, diffuse problem for which we are treating with a static, local modality. It will never work. Theoretically, it won't work. Because if it's local and you only put in 3 grafts, the heart attack is going to be all over the place because you never can really predict where it's going to be, number one. And number two, since it is static, it's not, even the grafts themselves deteriorate quite rapidly. This is the dietary regimen that is the treatment for diabetes and heart disease. The first step, vitamins and minerals we talk about later, but the first step is this. 70 to 80% carbohydrates. You cannot do that except by going to vegetable sources. The reason you can't do it except from going to vegetable sources is that only vegetable sources have carbohydrate. You can eat all the shrimp and the fish and the skinless chicken you want, but there's no carbohydrate in those foods. Simply reducing fat is not enough. You've got to have an increase in carbohydrates, and you've got to have an increase in fiber. There is no fiber in animal protein. So you've got to have an increase in things, grains, beans. These are my 2 favorite foods in terms, if I can get my patients to eat hot oat bran cereal 4 times or more a week, and beans 3 to 4 times a week, and some meal, just that, then I will drop their cholesterol levels in a measurable and predictable manner in everyone, regardless of whatever else they eat. But then if they eat this in general and concentrate on the grains and the beans, then they will have rather dramatic results. Well, this is very popular in this country. Americans are very macho about the way we do things. The bypass operation is not nearly as popular in Europe or in European other countries as it is in this country. And it's just plain not necessary. This is what you call the triple bypass operation. These are veins taken from the leg. This is one of the arteries around the left side of the heart, the circumflex. This is the one down the middle of the heart called the left anterior descending. This is the right coronary artery. And often we will use, the mammary artery, which gives blood supply to the ribs. Now, bypass surgery has failed 2 controlled trials to prolong life. It did not prolong life in the Veterans Hospital study in 1977, and in the CAST study, it didn't prolong life. And in patients who were bypass candidates but were treated medically, they had an overall death rate with medical treatment of less than 2% per year. Now, I will tell you, this was published in 1983, that it is a mathematical impossibility for bypass surgery to work. It cannot work. The reason it cannot work, you have a yearly survival rate of 98.4%. Let's say bypass surgery saves lives. Well, you're only looking at less than 2 out of 100 per year that are even available for saving. Everybody else lives anyway. So if bypass surgery cuts the death rate in half, you save 1 out of 100, but you have to operate on the entire 100 because you don't know who you're going to save. So it is a mathematical impossibility for patients to be helped by bypass surgery. But that's not what patients are told. Patients are told they're a walking time bomb. We better get in there immediately. If you leave the hospital, you got to sign out against medical advice. And consequently, we have 300,000 operations per year of patients who are misinformed about what their risks are. This is the graft of patients that are medical and surgical. It's one line. No difference at all at the end of 5 years, and this is roughly in those that have ejection fraction of greater than 50%. So mathematically it is impossible. If we look at the death rate in the state of California, in 17,000 procedures, they have a 5% death rate, 4.6% death rate. Some hospitals have as high as 14% death rate. Here is UC Medical Center in San Francisco, 14.7% death rate. Hollywood Presbyterian, 14.5 death rate. Santa Clara Medical, 13% death rate. Well, we have a procedure that on average is roughly 4 times more deadly than the disease. See, if you have bypass, you have a 95% chance of surviving. If you don't have it, you have a 98.6% chance of surviving. But in reality, those who survive bypass are convinced that the bypass operation is the reason they are alive. Basically, it cannot statistically alter the death rate. Now, the medical industry is not governed by anything remotely rational. In 1977, the Veterans Administration Hospital study showed that bypass surgery did not prolong life, and the death rate in the medical group was only 4%. 96% survival in those candidates that did not have surgery. In 1983, again, bypass surgery showed that it did not prolong life, and there was a drop to less than 2% death rate in medical therapy. This is the exponential growth of bypass surgery. There wasn't even a notch in the curve at the publication of these very expensive controlled trials, which completely undermined what physicians are telling patients. So we're not remotely controlled by the scientific literature. And it goes both ways, because this was a study published by Dean Ornish, who's since written a book. This was published in 1983. He took 23 patients and compared them to other patients out on a farm, gave them a vegetarian diet, and taught them how to meditate. He did this for only 3.5 weeks, 24 days. I think it's 24, yeah, 24 days. That's as long as he could get the result. He had gone 30 days if he had given him 6 more days, but he only had 24 days. This is what happened. Every aspect, and we go over this more later, but every aspect of their condition improved at a highly significant event. How many physicians do we have in the audience? Those of you who are physicians and read scientific literature understand what a p-value is. A p-value is a measure of statistical relevance. The lower this number, the greater is the statistical relevance, which means that the observation was caused by the intervention. In other words, there was a difference of 44%. Was that significant? It was highly significant. This improvement could have occurred only at a chance of 1 out of 1,000. This improvement would have occurred by chance only 1 out of 10,000. Look at the overall improvement with diet alone. It is the most powerful tool available for the treatment of symptomatic cardiovascular disease there is. What are the side effects? Side effects are horrendous with this kind of therapy. Patients feel better. Sexual activity increases. They lose weight. Activity spontaneously increases. Glucose levels normalize. Blood pressure falls, and everybody feels better. Well, you don't have a therapy that's supposed to be this powerful and also has only positive side effects. Well, there's a negative side effect, but you can take Mylicon for that. Well, this study was then extended over a year. Oh, if we look back here, if the medical industry were controlled by anything rational, if it were controlled by a patient ethic, what is it that we can do for patients that will make them better? Then every single cardiovascular center should have picked up on this, which was published in the American Medical Association journal, and everyone should be validating this work. But no, we're spending our time putting balloons inside of people and blowing them up. That death rate is 2% off the top, 30% reclosure rate. My only question about angioplasty, the only question I have that is the only valid question that any reasonable person can ask about angioplasty is how much additional damage does it do? I don't think it can possibly have any long-term benefit. It has already failed one controlled trial in which the acute care patients who had the balloon did substantially worse than those who were treated with conservative methods. It hasn't even been studied in the others. And when we look at the people who are being ballooned, we know what their death rate is. It's less than 1% if nobody touched them. But the angioplasty has an across-the-board death rate of 2%, plus a whole host of complications that occur down the line. But people have this balloon, and if they survive, and even if their angina goes away, they feel great for 6 months until they have to have it again. But if we had a patient ethic, every university would have picked this up. But you can't make any money giving people rabbit food. Everybody knows that. The only way you can make money is to get investments to build a catheter that you can convince people that they need. Wrong way. I had a feeling this would be a friendly audience. Well, he did this for a year, and what he found that when you continue this for a year, again, it turns out to be the most powerful tool available. The diameter of stenosis measured in these groups had reduced. The coronary blood flow had increased, and you compare that to the diameter of stenosis increasing and blood flow decreasing in the standard care, and then you can say that if you want to improve cardiovascularly, you follow this regimen. If you want to get worse, do what your cardiologist tells you to do. Because this is what the cardiology group were. They were receiving the standard care with the medications, etc. Well, what we try to do in patients that I see is create the reversal profile. Now, the reversal profile gives individuals the optimum level of measurable parameters that can reverse the disease. You see, I'm a little resistant to the concept of magic in medicine because, you know, there's no magic pills, there's no magic this, but there are very powerful tools that can be used that can scientifically group you in groups of patients who can be expected to get better. That's the best you can do. You can't guarantee any therapy. But if you take the diet and exercise and add to it vitamin and mineral supplements, which I really don't have time to discuss today, but they would include CoQ10, L-carnitine, vanadyl sulfate, chromium picolinate, and you put these things together, then you have without question the most powerful tool at treating cardiovascular disease. Now, I know as a kind of a somewhat alternative physician, we have to make our patients better. You know, I may have 100 patients and 99 of them are improved. If one of them doesn't get better, then it's our fault, if you understand what I'm saying. In other words, those of us who buck the tide have to be better. Otherwise, we don't stay in business. You see, it's interesting, our perceptions. You see, our perceptions are what guide us, our beliefs. And it is the perception that governs what is acceptable and what is not acceptable. A good example is John Wayne has cancer, terminal cancer, checks into UCLA for the top, checks into UCLA for their top therapy, dies at UCLA. Steve McQueen has cancer, terminal cancer, goes down to a Mexican alternative therapy in Mexico, dies in Mexico. Well, Steve McQueen went to a quack clinic, and John Wayne now has a memorial center. Both of them died. Both approaches were failures. But our perception is that UCLA has to be right. So UCLA takes John Wayne's name, who died there, and gathers money to the John Wayne Memorial Cancer Foundation. You see, Steve McQueen, those people down there wish he'd never come. So our perceptions is what govern. Consequently, if you're rational, or if people are capable of rational thought, which is a true question, then to look at the data and to assume that what we're doing in this country for heart disease and diabetes is the best of all possible worlds, you know, is an irrational assumption. Okay, I have about one more minute. I can take one or two questions if anyone has one. Yes.
Correction, John Wayne died of a heart attack at an operation that was ill-advised by his Mexican doctors down there.
Oh, Steve McQueen. Good, I will quit using that example. Yes.
When you talk about regular exercise, how much do you recommend on a regular basis?
There are two forms of exercise. There's isotonic exercise, which is aerobic, that's walking and jogging, and there's isometric exercising, which is weightlifting or working the muscles against a resistance. The best overall exercise is isotonic or aerobic exercise. Now, that exercise would be walking, jogging, swimming, and the like. So, of those, I would recommend walking primarily because it's the easiest. Walking or slow jogging. When I was working at Whitaker, we used to have a thing called wogging or something like that. Anybody remember where you would walk a little bit and then you roving? Yeah, where you'd walk a little bit, then you'd jog, trot a little bit, and then you walk a little bit, trot a little bit. And if you do that for a half hour or 5 times a week, you are in the upper 1.2 percentile of all Americans. You have no idea how much activity simply a half hour a day, 5 days a week is. Yeah.
What kind of a reaction do you receive from an unfriendly client?
What kind of a reaction do I receive from? Usually I'm not invited. No, it's basically I try to stay relatively scientific in giving source material for everything that I try to recommend, and I think I have enough controversy that has good source material behind it that I'm relatively challenged on the things that I'm talking about. In other groups, a lot of the vitamins and minerals, you see, it also has excellent source material. Another question, yes?
I wanted to ask you about beta-carotene for diabetics. I know it's in your formula, Forward, which I use. I read in Life Extension that they say it cannot be converted in the body to vitamin A for diabetics.
Okay, the question is, what about beta-carotene in diabetics? And the Life Extension, it can't be converted to in the body. I'm unaware of that. I'll have to research that, but I've never heard that from any other source. If that's the source, and I'll have to take a look at that. There's also some other things in the diabetic that gives people some concern, and that is vitamin C. They say in the diabetic, vitamin C can't be adequately converted, and it goes to dehydroascorbic acid, and that has some toxicity. But I've never seen the results of that. And so I can't comment on that, but I'll look at the answer to that. Well, if we're going to keep things on schedule, I've taken 2 extra minutes, so I will stop now. Thank you very much.
Very good. And, Doctor, as always, we want to present you with a commemorative plaque. Also remind everyone, I've seen Dr. Whitaker in action before, and a lot of what is going on right now will go on at the seminar tonight, so don't forget that at 6 o'clock. Let's give Dr. Whitaker another round of applause.